My name is Dr. Ravi Andrews and I'm a nephrologist. And today we're going to talk about urinary tract infections. And the main focus is going to be the causes, the definition, the types, and also I will dwell a little bit on the management of urinary tract infections and how to prevent infections and then infections which lead on later to kidney dysfunction and other long-term downstream problems. Before we go any further, let's just look at the urinary tract, the anatomy of the urinary tract, so we can understand what are the types of urinary tract infections that are there. So as we can see here, this part from the bladder and below is considered the lower urinary tract, and that includes the urethra and the bladder. And anything above the bladder, including the kidneys and the ureter, is considered the upper urinary tract. So infection of the urinary tract could be either involving the urethra, that's called urethritis. It could be involving the bladder, that's called cystitis. And it could be involving the kidneys, that could be pyelonephritis, which could be acute or chronic. Sometimes you can have abscesses or collections of pus in the kidneys as well. Long ago in 1960, somewhere, I think 1963, Cass put forward his concept of urinary tract infection. And this is the definition of urinary tract infection that we follow even today, 50 years down the line. So basically what Cass said was anybody who has a bacterial colony count of more than 10 raised to 5, that means 1 lakh colonies per ml, if they're asymptomatic, and if the urine which is collected by a midstream clean catch procedure, they have 10 raised to 5 consecutive samples. That is significant, and that is the definition of urinary tract infection. Now, unfortunately, this definition doesn't encompass all the other urinary tract infections. For example, somebody who's got symptomatic urinary tract infection, they might have a urine culture of even less than 10,000 or 10 raised to 4 or 10 raised to 3. So if you use Cass's concept, it was found that more than 50% of symptomatic urinary tract infections were being missed because everybody was waiting for a colony count of 1 lakh, whether the patient was symptomatic or not. So in 2010, in Infectious Disease Society of America, they added a few more categories to the definition of urinary tract infection, and they added on the symptomatic bacteriuria. So in a symptomatic patient, if the midstream urine culture shows 1,000 to 10,000 colonies per ml, that was considered significant and you need to treat it. Prior to this definition, only those who had colony count of more than 1 lakh were being treated, and people who were symptomatic but had less than 1 lakh colony count were not being treated, and that was just not appropriate. So because of this new definition, now more people are being treated, more urinary tract infections are being diagnosed and identified. They also added a few other caveats. For example, if you put in a urinary catheter, you put a fresh urinary catheter using all the sterile techniques that are available, and the first 10 to 15 ml of urine that comes out from the fresh catheter, even if there are 100 colonies, that is significant for a urinary tract infection. And if you're going to do a suprapubic aspiration, that means you do it from the top of the bladder with a needle with complete sterile technique. Even if you get 1 colony per ml in that particular sample, that is considered significant. So this is what the definition today of urinary tract infection is. If you're asymptomatic, 10 raised to 5, but you need 2 consecutive samples. If you're symptomatic, 10 raised to 3 or 10 raised to 4, that's significant, and a single sample is enough. If you're putting urinary catheter under fresh conditions and completely sterile conditions, 100 colonies per ml is significant, and if it is suprapubic, 1 colony itself is significant and needs to be treated. Now let's look at, there are different ways to look at the types of urinary tract infections. For example, you can look at it from an anatomical perspective. You can look at it from an etiological perspective. You can look at it from a pathological or pathogenesis kind of perspective. So we look at all these different methods and see what are the ways that we can distinguish or differentiate urinary tract infection. If you look at it from an anatomical perspective, you divide it into lower urinary tract infections and upper urinary tract infections. Lower urinary tract infections would, like I said, remember the picture that I put up? So it's urethritis, cystitis or bladder infection, and prostatitis. Among these lower infections, prostatitis is the only deep one that is a deep urinary tract infection. The others are mucosal. Going up to the upper urinary tract, acute pyelonephritis where the kidneys are involved, or chronic pyelonephritis where multiple acute infections can cause a chronic infection and cause chronic pyelonephritis, and abscesses, so native valves or from infective endocarditis, prosthetic valves. They can be abscesses which can come along the bloodstream, seed in the kidney, and cause abscesses there. Sometimes you can have local abscesses which spread into the kidney, and these can cause perinephric abscesses. So these are all upper urinary tract infections. The thing to remember here is many a time you can have a coexisting lower as well as an upper urinary tract infection. For example, you can have a cystitis along with an acute pyelonephritis. You can also have combinations of lower tract infections. You can have cystitis along with prostatitis. It's important to distinguish between these because the dose, the kind of antibiotic, and the duration of antibiotics will depend on whether it's an upper or a lower urinary tract infection. And like I said, many more than one site can be involved, and it can also be asymptomatic. We expect it always to be symptomatic, but then that's the whole point of asymptomatic bacteriuria, where you would consider it as an infection even though the patient has no symptoms. Another way to look at it, how to differentiate the types of urinary tract infections, would be the etiology. And this can be subdivided as bacterial and non-bacterial. Bacterial, the commonest cause of urinary tract infection is E. coli. This, most statistics say 80%, but there are some countries, even in our country, where up to 90% of urinary tract infections are caused by E. coli, which is an enteric bacteria which migrates into the urinary tract. The other organisms are Proteus, Klebsiella, Enterobacter, and more rarely staph and enterococci. But staph and enterococci are extremely rare. If you find them in your culture, you should definitely think of it being a contaminant and probably reculture it to confirm. Among the non-bacterial causes of urinary tract infections, tuberculosis, mycoplasma, these are the mycobacterials. You can have fungal infections, most common being candida. You can have viral infections with herpes simplex, CMV, and polyomavirus. And finally, you can have parasitic infections with schistosomia hematobium. Again, I want to add on that this can be symptomatic or asymptomatic. We can divide it according to the epidemiology. For example, we can divide them as community acquired versus hospital acquired. So community acquired are things which are just picked up in the community, and most of the time, in fact, all the time, they're not associated with urinary catheters. Whereas hospital acquired or nosocomial urinary tract infections are often associated with catheters, and then there's a new term for it. It's called catheter associated UTI, and these are notoriously difficult to treat. I'll go into detail about each of these things later on. Let's just get the basics first. Another way to look at urinary tract infection is to see whether the pathogenesis. So if they're an ascending, which is more than 90%, so they start off in the skin or urethra, starting with the skin bacteria, and then ascend up into the bladder and into the kidneys. That's an ascending infection. That's an ascending urinary tract infection, and that covers more than 90% of UTIs. Sometimes in those who are immunosuppressed, like post-transplant or post-malignancy, or somebody who's taking immunosuppressant for whatever reason, and if they're chronically ill and malnourished, they can have descending infections where somewhere there's an infection somewhere else. That is the focus, and that goes into the bloodstream and enters the kidney and goes down into the bladder. Again, could be symptomatic or asymptomatic.